Hi everyone, I'm Cass and this is the Mind Your Being podcast, a space where we'll explore health and what it really means to care for our whole being, our physical, mental and emotional health. Each episode you'll hear from leading health and wellness experts or everyday people who share powerful insights and lived experience. And sometimes it'll be just me, sharing thoughts, tools and reflections from my own journey. More than anything, I want you to feel supported, encouraged and empowered to make informed health choices that feel right for you. If this sounds good to you, please enjoy. Good morning everyone. Today I'm speaking with Professor Jayashri Kulkarni, who is the founder and director of the Her Centre Australia, Monash University. And I'd like to welcome you to the Mind Your Being podcast this morning. I'm so grateful that you've agreed to have this conversation with me today on such an important topic, which is women's mental health.
Delighted to be here, Cassandra. Thank you so much for inviting me, and you'll find it difficult to stop me talking about my favourite topic.
Awesome. It's one of my faves too. Thank you. So firstly, I'd like to start with asking you to share with us a bit about your background and what inspired you to focus on women's mental health in your research.
So I qualified as a doctor and graduated from Monash University. I haven't gone very far, have I? So I'm still at Monash University. So I graduated from the university with a medical degree, and then sometime later I did a whole lot of other things in medicine, emergency medicine and so on. And then eventually I decided to specialise in psychiatry. While I was specialising in psychiatry as a junior registrar, I had the opportunity to work at what was a institution back then, Royal Park Psychiatric Hospital. It was the big psychiatric hospital in Parkville. And as part of the rotation that I did there, I was working in the women's unit. It was called chronic illness unit. And there were women there who'd been there as inpatients for 10, 20 years. It was a very different world. A lot of what I did there was to talk with the women and understand and try and hear more about their stories. And I was quite struck by a number of things that the women themselves told me, which was a number of them had no mental ill health until they'd had children. And then obviously what had started as a postnatal condition, either depression or psychosis, had just continued and there had been no abatement. There were other women who described menopausal mental ill health, and one of the patients actually said, "It's my hormones, doc." And I thought, that's interesting because she said, "No one believes me, but it's my hormones." So that phrase stuck with me, both parts, that no one believes me and that it's my hormones, because I thought, there is so much that needs to be done for women with mental ill health. And that really piqued my interest. In particular, the working with hormones as they impact on women's mental health was one big factor. But the other factor was also invalidation and the non-consideration of women's mental health as a separate whole field within mental health. And the third thing was that was a really horrible ward. I mean, it was the state of most of the facilities, psychiatric facilities at the time, that they were just Dickensian old units that just were not at all very conducive to the milieu being helpful in healing. And so again, I thought we've got to be able to do better than this on all counts. So that kind of got me fired up from a very early stage, and I'm still fired up.
I can hear that in your voice, and in researching for this episode, that really struck me. A number of times I've heard you say that you're really listening to the women. You're not just like, what's the research pointing to? You're actually taking into account what the actual patient is saying, which, I think is not always the case with medical professionals, and I think it's really helpful.
Thank you. But I think really most academics, particularly clinical academics, the hallmark is to be curious. And, to have that privilege when, particularly in psychiatry, I get to spend a long time with patients. I mean, our poor general practitioners who have to rush through in 7 minutes or whatever per patient, they don't have that luxury, but I do. And it's really an honor and a privilege to sit and listen and to ask questions about, why. Sometimes I might sound like the annoying 3-year-old, but why? But why? But it's like trying to
Curiosity.
yes, it's trying to get to what's happened. And often I think that the observations that many women make of their own illness or state of mind or whatever it is, that they will have hypotheses about this happened, and then bang, I got really depressed. And that's really critical because, with research background and knowledge, what you can do is you can work collaboratively to turn those observations together into the next research project. Then feedback results to the person who gave you the ideas, and you work together to then see if that's helpful in a treatment sense. So there's a virtual cycle that keeps going on that, you're talking, you're hearing, you're listening, you're making ideas, you're using your expertise and knowledge to add to those ideas and develop the research, then test the research, then see what comes out and then retest and so on. So it's a lovely ongoing process. And I think as a clinician, I'm really very privileged to work directly with people and then also to implement things that we found in research directly. So we're not hanging around working with animal models and so on, and then you've got a 20, 30-year lead time. I mean, we do need animal model research, but other people are doing that.
But you can see it a lot quicker, whether treatments are effective, and you're getting
Yeah.
that real-time feedback.
Yes, and also, why? What happened to this individual that
Yeah.
she got sick in the first place? What went wrong in her world for her that things ended up the way they are? And I think that's really critical to inform research. It can't be done in a vacuum, like just some kind of just sort of isolated symptom checklist or whatever. Doesn't really hit the point because you miss things that are really critical.
It's a
But
more holistic
long,
approach.
yeah, very holistic approach. Long answer to your very short question, but anyway.
No, it's a wonderful answer. Thank you. Yeah, I really appreciate that you do that, because who better to tell you, to talk about what's going on than the actual person who it's affecting. It's great. Just stepping back, as I alluded to in the introduction, you are the director and founder of the Her Centre Australia, and also the multidisciplinary Alfred Psychiatry Research Centre. I was just wondering if you could tell us a bit more about the mission with these research centres and some of the important work that you're working on.
So the multidisciplinary Alfred Psychiatry Research Centre is governed by Alfred Health, and all of the work we do is sitting in the Alfred Health campus and affiliated with Monash University. So the MAPRC is Alfred governed, and interestingly, we sit within that section of Alfred Health that is called Alfred Brain. So we work alongside neurologists, neurosurgeons, neuroscientists, and we've done this because I think this is a really important step forward, that in psychiatry, we must not forget that the organ that's driving behavior, thinking, emotions, cognition, the whole lot is the brain. Obviously, in the context of the person's environment and all that that contains, but nonetheless, sometimes when a lot of work is done in psychiatry, the brain is kind of missing in the actual consideration. And when I look at what advances our neurology friends have made, they've made considerable, great advances in the treatment of strokes, of multiple sclerosis, migraines. I mean, you name it, a lot of different conditions, epilepsy in particular. I mean, a lot of conditions that when I was a medical student didn't have great solutions have really got very good treatments now. And I look at that and think, hang on, why don't we have that in depression, in schizophrenia, in bipolar disorder? It's again useful to think about things differently. And I think sometimes it's really critical that if we're going to make strides forward and innovate mental health, I think we need to go outside of our usual psychology, psychiatry, and other mental health discipline experts and actually find out what's going on in other branches of medicine and even, philosophy and all sorts of different places.
Yeah.
Might have the answers for us, or at least give us new thinking so we can then proceed with different approaches. So that's the MAPRC. Her Centre, which stands for Health Education Research, that's the HER, is a Monash University governed centre, but with Alfred affiliation. So we've got both. So one's Alfred governed and with Monash affiliation, and the other one is Monash governed and with Alfred affiliation. So the difference is in MAPRC, we're doing a lot of clinical trials in all different conditions, and people of all genders are involved in that. In Her Centre Australia, we have dedicated the work to finding out more about women's mental health services, and also advocacy for women with mental health. Now, our definition of the term woman is a broad one. So we include people who are assigned female at birth, but then also those who identify as a woman. I mean, being inclusive is really important to me. So that's why we've set up Her Centre Australia, is to include women with lived experience as part of our research advisory groups and so on, so that we're all in it together to try and come up with better outcomes.
Wow, thank you. That's a wonderful overview of what you're doing there. It's so important. And again, I can see the thread is that it's inclusive. You're looking at the holistic approach, which I think is the best way forward. So that's great.
Particularly important in women, that, I think it's important anyway, but for women, I think a holistic approach is really, really critical when we look at the cause and then the treatment of mental ill health.
So at this point, I just wanted to point out to the listeners that given the time frame today, we're going to be talking about women's mental health, but we're really going to focus primarily on women's mental health in the midlife stage. So I'll just start off with some basics. So when you're talking about mental health, how do you describe it to people in general terms?
So there are many definitions of mental ill health, but I think the best one is the subjective distress that people feel when they have emotional, behavioral, or cognitive, that's higher thinking, difficulties that impairs their capacity for work and love. So mental health is that sense of well-being that allows somebody to pursue a good quality of life. And by that, I mean in that they are able to hold down work that they love or want to hold down, and that they've got a relationship that they love. And that they're broad terms. So work is not necessarily about being the best paid, stockbroker or something. It's any work that is meaningful to the individual. And relationships similarly. It's relationships with love of a child, love of another human being, love of a family member, whatever it is. But, again, both broad domains. But it really is about good mental health is having the capacity to have a good quality of life as measured by feeling happy in work and love.
I love that because, it's about the quality. Like everyone has mental health. It's part of our health, but it's about the quality of the mental health.
And the subjective distress is what we work with. It's not about, somebody else saying, well, she's not up to scratch or she's not doing this well or that well. That's not it. It's what does the person think, feel, and how are they wanting to behave and feel complete and fulfilled. And that's the pointer to say, if that's not working for her and she's seeking help, then we can help her.
Because everyone's different. Everyone has a different background or different ways of coping and whatnot. So
yes.
Could you help us understand what kind of factors can influence someone's mental health and why it's important to look at all of those factors when addressing any mental health concerns?
Look, I like the term, which is a bit hackneyed, but it works, biopsychosocial, which is biological. That's the, particularly brain, hormones, brain chemistry, physical health, all the biological factors that are impacting on the individual. Then psychological factors. So we're all programmed to deal and cope with stress with our different ways that we deal with conflict. For instance, some people avoid it, some people are very confrontational. Other people will deal with conflict by making it somebody else's fault. I mean, all sorts of different things. That's psychological. Then there's the social, and I put into the social all the big things like cultural and religious, the socioeconomic, ethnicity, all of those factors that go into making up the person's own particular contextual world. So factors in there will impact on brain biology, which impacts on how it's expressed in terms of psychological behavior. And the psychological behavior will have an impact on how this person is perceived in their world and so on. So they're all interactive, but it is important to think about the different domains when we're looking at why did this person get sick in this way.
In your work, do you see differences between women and men in terms of the type of mental health conditions and the effect of these issues?
Absolutely. And I always make it a point to say this isn't a race, or a competition between who suffered worst, because no one's winning that one. But this is about actually picking the gender differences or the sex differences. And unfortunately, a lot of the things that have created mental ill health in women haven't really been put into mainstream consideration for treatment. And for a long, long time, the whole field of violence against women was kind of ignored or not given a very prominent place in terms of how it impacts on women's mental health. And that is a big difference. Men, of course, can be subject to violence in early life or abuse. We know that. But by and large, there are more women experiencing domestic violence and interpersonal violence, and then that gets translated into changes in brain chemistry, which then leads to mental health symptoms. Psychologically, and because of the social context, women may not have generally as much power in community or societal settings, or even in the interpersonal dynamics. They're not actually equal partners in many cases, or some cases, many cases in the people I see who are in distress. But, again, all these factors really impact and are different between men and women. I think male mental health is another important area that needs its own consideration, particularly as we move into new generations and different models of masculinity. And I think that's also very, very critical. But that's not my area of expertise, because I've worked for quite a while to carve out this particular area for let's do something better for the many, many, many women who are still struggling. But I don't want to diminish the fact that we do have many men who are suffering as well.
I appreciate you saying that, and I don't want to diminish that either. And I'll be having those conversations on the podcast as well. But like I said, given the time frame today, we're focusing on women's mental health. So speaking of those differences, when we're talking about mental health, what are some of the main hormones involved and how do they impact our mental health?
So I might just jump to the midlife, talking mainly about, because good encapsulation of where things are different. People who are assigned female at birth, everyone goes through menopause. You can't outsource it. It is an inevitability that women will go through, or people assigned female at birth will go through menopause. The biggest hormone fluctuations that happen at this time are fluctuations in estrogen, progesterone, testosterone, and the precursors to those hormones. These are called the gonadal hormones. Why? Because they're mainly produced by the gonads in women, that's ovaries. However, estrogen is produced elsewhere as well. It's produced in fat tissue and other places as well. But the main bulk of hormone, estrogen, progesterone, testosterone, produced in the ovaries under the control of the brain. So this is why at menopause, these hormones are not just about reproduction, not just about fertility and having babies. These hormones are potent brain steroids. They really do drive brain chemistry. So at menopause, when there is a fluctuation, not just a gentle decrease, quite a fluctuation. So it's the fluctuations in estrogen, progesterone, testosterone, and their precursors in the brain that can set off different brain chemicals to then create thought changes, emotional changes, behavior changes, and difficulties with thinking. So the most common mental health symptoms that women describe in their early 40s, and it begins in the brain. The menopause transition is about a 10-year process, beginning in the brain first in the early 40s. This is not the older women's story. This is the younger women's story in terms of early 40s. The first lot of symptoms is anxiety goes up, even if there's nothing particularly in the environment that this woman has that's causing anxiety. Then panic attacks can happen because the anxiety really reaches a crescendo. Depression, sadness with tearfulness, and this awful thing called brain fog, which is the phenomenon, it's a cognitive change, but it's a phenomenon where women describe difficulties remembering 10-digit numbers or just remembering lists or having difficulties thinking through processes. So, for example, I saw a highly skilled computer analyst who said she stood there one day in front of her computer and couldn't work out how to turn it on. Something that, is second nature to her that she just had to really struggle with. And that obviously was terrible for her. So that's an extreme example of brain fog. So those main things happen first. And then there's also changes in sleep, changes in appetite, either way, can be, increased or decreased. But overall, there's about a 2 to 8 kilo weight gain in general. Even if there's no change in appetite, no change in exercise, there's a change in fat metabolism. Tiredness, of an extreme sort of tiredness, not just because the person has done a lot of stuff, but they're actually descriptions of, I just feel so weary that I can't even lift my hand to brush my hair, that sort of weariness. Changes in libido, usually decreased libido, so there's no particular sexual appetite. And for those who are having penetrative heterosexual sex, it can be very uncomfortable because there can be changes in vaginal lubrication and difficulties with painful sex. That can be another issue as well. So irritability and hostility are often seen, that there's just a sort of lower tolerance for things going wrong. But all of this fluctuates. It's not just a constant sort of thing. It can be there for a couple of weeks or even 1 week, and then suddenly the woman wakes up and says, oh, it's gone. I don't know what that was, but it's gone, and let's not worry about it. And then it comes back about, 3 weeks, 4 weeks later. And this is because of the fluctuations. So estrogen is particularly good for the brain. It does kind of have this nice calming, not calming, but it has a more energizing effect. It's progesterone that has a calming effect. So when these hormones are in flux, it can create these disturbances. Some women experience the disturbances much more than other women. And going back to my trauma quest to find out more about what's happened with early life and subsequent traumas, it's the women who have those stories of early life emotional, psychological, physical, or sexual trauma that seem to have greater vulnerability to these hormone fluctuations.
I really appreciate you pointing out that it's not just at the time of menopause, it's actually a whole period of years. It can be 10 years. It's definitely in your 40s leading up to the menopause transition. And I think that's really helpful because I know myself, I've only just found out about it more in the last couple of years. I didn't realize how protective the hormones are of your brain and your heart. And so, yeah, I thank you for pointing all that out. So there are no definitive lab tests as such to tell patients when they're experiencing menopausal depression, as you say. So when would you advise women to seek help from a health professional?
Yeah, this is one of the difficulties, the transition into menopause, as I said, it's a 10-year process, is called perimenopause, around, right? So perimenopause is a long process, and many general practitioners and other doctors will do a blood test and go, oh, look, there's nothing wrong with you for the 43, 45-year-old woman. That's true. There isn't anything wrong because her brain hormones are not measured. If we could measure the brain hormones, we could see the flux that's going on there that's creating the issue. But her body and everything else is fine. Once the hot flushes hit at about 52, 53, then everybody's smart retrospectively and goes, oh, that's what it was. But she's struggling through. So again, I go back to, when should women get help? When she's feeling like she's not coping. And I would say to women, can you back yourself? If you're a 44-year-old woman, you know what's normal for you and you know what's not right for you. And you also, know what's environmental. Like if you're having major relationship difficulties or workplace difficulties, then you know that that's going to upset you. But if you're not dealing even with those things in your usual way, that there's something else that's going on. And people will often say that. I knew instinctively that there was my hormones. It's my hormones, doc. Again, just shout that out loud. Take some information and material from various websites, our own website that Cassandra will post on here, or the Australian Menopause Society website, International Menopause Society website. Grab hold of information and share it with your treating doctor, because they may not be aware of it, that mental health is impacted by menopausal hormone shifts.
So, in your clinical practice and with your research, with the menopausal depression and the anxiety that some women are feeling, what have you found are the effective treatments that can help with these changes?
Well, at the moment, we're actually conducting a head-to-head, what we call head-to-head clinical trial of standard HRT. The trendy name for that is MHT now, menopause hormone therapy. So standard menopause hormone therapy compared with a standard antidepressant, and we're using sertraline. So we're conducting this clinical trial. So if any of your listeners are interested, again, please contact our centre. But that's the two pathways that people have got open to them. That, if they're in early stages, it may not be that the treating doctor has twigged that this is a menopause issue. It might be that they think, oh, well, there's a lot going on and maybe you could try an antidepressant. It's not wrong, but it's not going to be getting to the cause of the issue. If you are able to strongly make your case for hormone therapy, then that is the other pathway to try. And as long as you don't have breast cancer yourself or a very strong family history of breast cancer, or if you've had a DVT, which is a clot in the leg or clotting in the lung, they're the things that really rule you out of hormone therapy. But other than that, if you're healthy other than that, you can try MHT, menopause hormone therapy. So there are a number of important medical follow-ups that midlife women, everyone should have. And that includes regular pap smears, regular breast screening, regular blood pressure checks, regular cholesterol, and all of those things. That's just good to set you up for a healthy older age. So everyone should have that. And particularly if you're taking other medications, you should definitely be having all these screening with your local doctor. So there are two pathways, either a hormone therapy pathway or an antidepressant pathway, or there are other pathways, the natural medicines pathways that many women try. They go down to their chemist or health food shop and they try various products. Sometimes, a lot of money is spent on things that aren't particularly useful, so that can be difficult. But other times, people feel a sense of control with natural medicines, and that's not to be disregarded. So I come back to the subjective distress. It's about what works for you and what hasn't worked for you, and at what point in time do you feel distressed enough that you want some help. So it's really about the individual person making up their own mind about what they want and when they want it, and making sure that their voice is heard.
again, in researching for the episode and menopause in general, I wasn't aware that GPs and even some specialists, the training that's received in medical practice, how much training do they actually receive with regard to menopause?
Absolutely minimal. It's just not good. This is one of the things that, again, I've been battling trying to get women's mental health, women's health a bigger platform. Women's health is getting a little bit more attention, which is good, but women's mental health is still down the bottom of the barrel. And that's ridiculous when you think about all of the trauma, all the lost productivity, lost parenting, broken relationships and significant distress that many women go through and could be helped. So again, yes, the teaching and training is not good, but we're all trying to get some more about that. But that's why I'm saying, the individual person who's got an insight into herself and has a sense of this is what I think is going on, you need to again push that because your particular GP or whichever doctor you're seeing may not have had that particular training. And so it doesn't mean that they can't get more training now, and maybe working with you collaboratively, they will also be able to upskill themselves and then help the next woman that comes in.
But it's so common for women to go, oh, well, it's just part of life and I'll just have to suck it up. But if there's women out there, they feel like they're not taken seriously or they're not getting the help they need. Do you have any other advice to help them advocate for themselves when they're talking with a GP or a specialist?
So I think you give it a good go with the resource material. Jean Hales has other material as
Yeah.
well. So, there's some organizations around that are very good at producing the good material. But, give it a good go, taking the material, having a good discussion. But at the end, if you really are not getting anywhere, go find yourself a different primary healthcare practitioner or GP. And there are some really lovely women's health clinics that have women front and center in their considerations.
So, with regard to our current medical system in Australia, I've heard you say no one owns menopause.
Yeah.
What do you mean by that, and how can that affect the quality of care that some women are receiving during this time?
So if you think about medicine is practiced in silos, in little bits here and there, right? So anything gut related, there are gastroenterologists and gastroenterology surgeons who deal with that. There are, orthopedics deal with bones. And so, you have all these different specialties. When it comes to menopause, there has not been, up until now, there are now becoming menopause specialists, but they're still very far and few between because menopause is such a big process. It involves, as we've been discussing, the brain in terms of mental health. It involves bones in terms of osteoporosis or osteopenia and bone health. It involves the reproductive organs, so, ovaries, uterus, changes in fertility, changes in lubrication, all of those aspects. Then there can be breast health. So, again, there are tissues that can be impacted. Then there's all sorts of other body changes. There just are. There's fat distribution changes and so on. There's even immune system changes. So people can develop new allergies when they didn't have them before and so on. So this is what I mean by, there's a bit of a psychiatrist in there. There's a bit of a gynecologist in there. There's a bit of an orthopedic specialty in there. There's a bit of endocrinology, which is hormone. So again, it's not one particular field. And really the best person is the GP who's trained in understanding menopause, and where there are more of these GPs now, which is good. But for a long time, there wasn't. And so this is why I meant, that it's not a particular situation where one specialty owns it. Then you have the other argument, which is it's not a disease. So I obviously am seeing people when they're very unwell mentally. As a consultant in a tertiary hospital, that's what I do. I see very unwell people. However, there are millions of women who go through menopause with no problem whatsoever, or just a niggle or two of something, and then they just cope with it. So that's the other side of it too. It's not a disease. It is an inevitable process. I've no wish to medicalize menopause. So it's the bits that we're talking about are when people are really struggling. So again, I'm not addressing everybody who's got menopause. I'm addressing people, particularly in my specialty, who are severely impaired with the mental health aspects of the hormonal flux that creates this different sort of depression in women at midlife.
I just wanted to point out that the Australian Menopause Society has a list of registered GPs who also have more of a specialty and an understanding, maybe have done some further training with regard to menopause. So that is a great resource to check out. So we've covered some really helpful information today. Is there anything else you'd like to say or anything that we haven't covered that you'd like to share with the audience?
Look, my big bugbear in this whole area is that we still struggle to get the funding for research in women's mental health, which is, I think, ridiculous, but that's just the way it is. And so again, there are some really basic things that can be done, such as we have started this clinical trial pairing standard antidepressant to MHT or menopause hormone therapy. We've started that thanks to a small grant from the 1 in 5 Foundation, which is great, but we need a lot more to make it a bigger study so that then we can actually have definitive results that will help women to take to their practitioners, and their practitioners can have some evidence base to then be comfortable to prescribe MHT for those women who need it. So there's just a real imbalance in the funding issues that we're experiencing. Menopause is midlife women, and I think sometimes midlife women are not recognised in terms of the incredible things that they do to keep society together, really. It's the care of the young and the care of the old, and often also holding senior positions in our workforce. So I just would like to, if it doesn't sound too whingy, to say, we've got it all band together to be able to get some better funding, and even to just get women's mental health onto the platforms and the important considerations for policymakers and politicians.
Well said. I agree that there's just not enough research, and I wasn't even aware that most of the medical research until recent years, you would know better than me when, was all done on men. So if we're lucky enough to live to, life expectancy, about a third of our life as women is going to be lived postmenopausal.
Yep.
We need more research. We need more people to invest in research so that we can have a quality life in a third of our life.
Absolutely. And it is a really increasing area of need. And, I'm delighted that we've actually got a lot more people like you, Cassandra, making podcasts and speaking about it in the social context. Because, we can do research and then it gets published in journals, which no one except other colleagues will read. But that's not going to get out there. So it's important, this social education and conversations are really critical. This is not secret women's business. This is everybody's business. And I think this generation of women who are in their 40s and early 50s are making a good amount of noise. So I'd say keep going with the noise because you're getting there, which is great.
Yeah, definitely. I feel like, and maybe it's just because of where I'm at in life, but I feel like menopause is getting a bit of a moment and it's getting more talked about. I think, even just a couple of years ago when I started the transition and talking with friends, maybe like 2 or 3 friends, it felt like, well, this is something we talk quietly about, like nobody talks about it. But recently, I'd say in the last 6 months to a year, yeah, I think people are talking more about it, which is great. The more you talk, the more awareness and the more you can get the important research done. So as this podcast is called Mind Your Being, I'd like to ask you to share 3 things that you do. It could be a practice, a specific exercise, a particular food, anything you like that you personally use to help mind your being.
I used to be a runner for a long time, and then I hurt my hip. So I then turned into a walker. And I think it's one of the best things that could happen, because I make sure that I go for at least 5 kilometers, preferably 8 to 10 kilometers walk in the morning. I walk along a beach, and I'll often listen to music or a podcast or something, but then I'll stop and I'll actually look at the water. And I love that. And it's been a really eye-opener, because when you're running, you're just kind of running and you're trying to get the pace and beat your own previous times and so on. But when you're walking, there's a real mindfulness that can go with it. So I love my morning walks. Oh, what else do I do? I love movies. I love losing myself in movies. And my husband and I, and in the past, the kids, when they were living with us, and friends, we would often go to see movies. And it's just a lovely way of just losing yourself in a different world, but also kind of understanding where society's thinking, or what's the genre or mood out there. That's that one. And I do love socializing. I'm a social person. I'm not your quiet introvert, in case you haven't picked that up already. I'm a loud, noisy extrovert, and I love being entertaining, or having friends over, or going out and so on. It's all of those connections. So connection to our earth, and that's the grounded sort of walking and looking at the lovely surrounds. And we're very lucky in this country that we've got such beautiful scenery, and we've got to look after it. So, that connection to the earth, connection to my family, connection to my friends, and then connection to society more broadly through pleasurable activities like the films and reading.
Is there any particular genre of movies that you prefer, or just any that are coming out in general?
I stay away from the very violent movies. I don't like that, but I'm not particularly wedded to one or the other. Well, I just love going to the movies.
I think, as you were saying, with the mindfulness practice with your walking, I think movies too, you can just lose yourself and you can be just totally present. I enjoy it for that too.
Yes, absolutely.
Would you like to just cover off again about where people can find out more about you? I will provide links to people of where they can find you online. If you just wanted to mention the Her Centre again.
Yes, so Her Centre Australia is the HER, stands for Health, Education and Research. And we are based at Alfred Health, although our website address is Her Centre Australia, all one word, at monash.edu. So that's our website address. And it's all about women's mental health.
Thank you so much. I really want to personally thank you. I'm so grateful that you agreed to come on the podcast and share your expertise. It's been really enjoyable for me, and I know it's going to help a lot of women, not only for those women who are struggling right now for answers, but women in the future when they start transitioning in that period of time. So thank you so much. I really appreciate it.
And thank you for doing this. That's really great.
That was a wonderful episode, and thank you again to Professor Kulkarni. You can hear the passion in her voice, and what I love is that she really listens to the people at the heart who are suffering, and as she said, she incorporates what they tell her in the direction of the research, but also when they're trying treatment, she gets feedback from them that then gets fed into more research, and I think that's, just wonderful. So, I really enjoyed this episode. Thanks so much for listening to this episode of the Mind Your Being podcast. If you enjoyed it or found it helpful, please follow the show wherever you get your podcasts and share it with a friend who might enjoy it too. If you have a moment, please leave a quick review. It really helps others discover the podcast. Thanks again for being here. Take care, and until next time, mind your being.